Hello, Mark Brezinski. This is another lecture in the series from the Seath Health Corporation, or the Functional Movement and Fitness Corporation. And generally we title them, Why Aren't People Getting Better from Musculoskeletal Problems? Today I'd like to focus in on the origins of lower extremity and back osteoarthritis. And we're going to provide evidence that it's due to subtle gait abnormalities, primarily in Sittersdisease. The fact that we're bipedal. These lectures are educational and not intended to manage individual patients. They are not a substitute for seeing healthcare professionals. Among the reasons our patients vary, and no brief presentation substitutes for formal training, and you also need to do a thorough history and physical. Now, we're going to use these lines of evidence to demonstrate that the link between subtle gait abnormalities and OA, and because there are no studies that look at subtle gait abnormalities longitudinally and the development of OA. So we're going to make the argument through other approaches, including looking at primates, anthropology, our ancestors. But this is, OA in our weight-bearing system is because we're bipedal, if I got it right that time, and sedentary. And so monkeys who are in captive are more sedentary. They sit around and they get more osteoarthritis than monkeys that are in free range. And these are some of the conclusions we're going to come from analyzing these different areas, but I'm going to deal with this in the last slide. So we're going to talk about OA first and functional movement, and then move to gait, the relationship to gait. Evolution has designed us to be efficient long-distance runners and to minimize injuries. It does not design us to be sprinters. So Neanderthals are likely better sprinters based on the evidence than we were. And so with this efficiency, what we're talking about is storing. You need to do more than utilize energy the best as possible. If you can store ground force energy and impact energy to be released, then that's powerful for efficiency. But if you fail to store it, it becomes destructive kinetic energy. And that's an important part that's often overlooked. So what is the optimal gait to prevent OA? Probably evolution didn't design the gait to prevent OA unless OA developed earlier in our ancestors because of previous injuries. So, but if we look at the injury gait and the efficiency gait, that gives us a pretty good idea. When we looked at medical students, how many of them, what percentage of them already have in their 20s abnormal gaits? It was over 25%, 4 years in a row. The problem is this is a select group. It doesn't generally represent that age population, because medical students spend a lot of time just sitting around studying. So my name is Mark Brezinski. My background has been discussed on previous lectures, and you can read it if you want. But the one point is I've been doing this a long time. I started in the 90s working on, what's now called the Kinetic Chain, which then was the weight-bearing system. I don't really know where I started. This is dealt with in another presentation. But in 2002, I was on the Osteoarthritis Initiative for the NIH since its very beginning. And I was strongly opposed to imaging and wanted it to be more directed toward gait and kinesiology. The Functional Movement and Fitness Corporation, just so you understand, our focus is increased function with age, non-surgical injury restoration, injury prevention, and high-risk fitness, coronary artery disease, diabetes, hypertension. Now, I was pretty naive when I started this, and back in 2015, I approached the Brigham Internal Medicine and, said that this would require moving toward functional movement and true prevention, a 2-year fellowship. And that didn't go over very well, and I presented it to Partners, which owns Mass General and Brigham and Women's. And since then, I've come to realize you don't, at least for diagnosis, you don't need to know the muscles and the nerves and the skeletal system, each bone, which is what I thought back then. And some of it you do need to know for treatment, but a great source is if you want to know that stuff, along with really in-depth kinesiology, is Newman's textbook of kinesiology and the musculoskeletal system. I read the last edition cover to cover, and this recent edition back through foot and the walking gait. And if I write a book on functional movement, I'm going to be referencing a large percentage of it to go read this book. Great book. Osteoarthritis. So OA is not a consequence of aging, though so many people believe that. But people often say it's also not a wear and tear disease. And I think that's not technically correct. So when you have abnormal gait, for instance, or a torn medial meniscus, that is a wear and tear injury developing OA. OA is due to pathologic in-pressure delivery over long periods of time in the same area. And in order to prevent OA, we need to understand it. So this was an important study in Proceedings of the National Academy of Sciences in 2017. And in adjusting for BMI and age, the incidence of OA has doubled since World War II. And and obviously it can't be due to genetics. And they attributed it to a sedentary lifestyle. And I agree with them. That's what I think their data shows. Hunter, prominent researcher in the field, said OA is in its infancy, and I would have agreed in 2010. Now I think it's gone backwards and is still in the womb, because so much back when in 2000 we were asked by drug companies to develop animal models of OA combining with OCT to reduce the number of animals used in the time of the experiment, but there wasn't a lot of interest in pharmaceuticals for OA. They were mostly more focused on bone disease, and I think we would have got better reception and functional correction then than we would now, as pharmaceutical companies are pushing more for medications, which are very important. Let's face it, most people, a large percentage of the people, are not going to be compliant or only partially compliant. But we're not saying those are the causes. There's been a recent attempt to downplay the mechanical stresses that lead to OA and more focus on things like genetics and weight and even inflammation, which it's not really an inflammatory disease. But if you were to swing a baseball bat at my arm, genetics, my age, could play a role in whether my arm fractures. But the thing that's going to prevent my arm from fracturing is getting out of the way of the pressure load or the baseball bat. So similar principles hold with preventing OA. We've got to correct that pressure. Other things may contribute, but the big deal is getting out of the way of the baseball bat. Talented group, Lancet 2015 review, but they said that there's associations with abnormal joint mechanics in OA, but most abnormal joint mechanics don't develop OA. Well, that's true. The weight-bearing system is designed to take a tremendous amount of pressure. And so we're not saying all misalignments are causing OA. We're focused in particular on subtle gait abnormalities and how Sittersdisease contributes, or sedentary lifestyle contributes to an abnormal gait. Great paper by Felton, Star in the field. OA is caused by inappropriately directed or increased energy particularly ground force energy. I added the plus because there's more energy besides ground force energy. On joint components, shifting the balance toward structural breakdown over corrective mechanisms. Specifically, OA is caused by a shift in the center of pressure on cartilage, not necessarily the center of mass of the body, and increased energy delivery and poor, and I added these, and poor storing of energy during gait. And we're going to look at the ankle joint versus the knee joint. The ankle joint on the right is a Mortise joint. I hope I pronounced that right. The center of pressure, no matter how much you shift the body, doesn't change very much unless you've previously injured the joint. But the knee joint, you supinate, pronate, it shifts the center of pressure in the knee widely. Now, and that's shown in this slide. I call it the $700 slide. That's how much it cost made it from being made from a kinesiology program in the Midwest. But if you look at the ankle inversion, it causes shifts in the cop all the way up the skeletal system, in the knee, in the hip, in the back, in the cervical system, and even in the shoulders. And so with gait, it gets even more complex because it's a dynamic shift in the kinetic chain. And you do this 5,000 steps a day for decades, and it's going to cause problems. Now, kinetic chain, our COP is supposed to change, and I was listening or watching a course on Michelangelo yesterday, and this was very interesting. They pointed out how the kinesiology, the accuracy of the kinesiology in Michelangelo's David, when he sculpted the body in order to unleash the sling. And so we have a movable center of pressure for a reason, but we can't sustain it and we can't overuse the energy to it. So subtle gait abnormalities in OA. We are talking about the weight-bearing system here, the back, the knees, even the neck. And so on average, forces on gait are 2 to 8 times body weight. And that's not if you're constant, and that's distributed on the joint. If you make it focal, it gets worse. And the forces are ground force energy, deceleration, the muscle contractions across the joint, but also if you fail to store potential energy. And I have to say this is a huge area that's rarely dealt with. And also the center of, I'm using pressure because pressure is force or energy divided by the area. So the smaller the radius, the greater the pressure on the cartilage. You can see where this would, in patellofemoral syndrome, where this is devastating. Well, why does patellofemoral syndrome cause so much cartilage damage? When the patella is in the intratrochlear fossa, the pressure is spread across the patella, but if it hops up on top of the condyles, the same amount of force in that leg is distributed over a small area patella and causes tremendous damage. The other areas, the areas in white, I'm going to focus in on primarily here. I've covered to some degree the other areas, primates now, our ancestors, animal studies, and human studies. But when we're talking about our ancestors, there's been a lot in the literature about Neanderthals in Africa not having OA, and Neanderthals in Europe having OA. And that's related to the GD5 gene found in the Neanderthals that moved to Europe. But we don't have enough Neanderthal bones with osteoarthritis to make that statement. The statement is based on the fact the gene causes a short stature and an increased incidence, is associated with an increased incidence of OA And so we don't have, we're, with regard to our ancestors, we're learning about how we developed our gait system. So if we look at um, great apes, uh, great apes have less um, OA than humans do, and great apes that are free ranging have less OA than those in captivity or in, um, raised in a zoo. And this is, again, primarily a bipedal disease. Now, we did a study, I hate using animal models, let me start off with that, but at least we worked on developing an animal model to study OA combining with OCT that dramatically reduces the amount of animals needed and the time to get results. And we've presented it, but we haven't submitted it for publication yet. So on the left is the model. It involves cutting the ACL and the medial meniscus along with a few other things. It's highly reproducible. You get at week 2 disease in cartilage breakdown in the medial meniscus in week 4, in the not meniscus, sorry, medial tibial condyle, and at week 4 the lateral, and highly reproducible, so it's not genetic. And then when we tried doxycycline, a metalloprotease inhibitor, it delayed the onset of osteoarthritis, but ultimately the osteoarthritis developed, getting to this point that drugs are important, but we still got to reduce the mechanical problem. Now, we've presented, but our article is in submission, looking at OA in humans to predict the onset after a medial meniscal injury. And in our work and other groups' works, it's great to use the medial meniscal tear model, because 50% of the patients developed OA within 2.8 years. So it's easy to study, but the medial meniscus causes a change in gait. When we look at our ancestors, again, we're learning about gait, but we don't have enough skeletons. What we do learn, though, is how things are changing. And this is from the citation from Nature is below, but from Neanderthals 106,000 years ago, 87 footprints preserved in the sand from children's to adults, which gave us a great idea. It gives us, among other finds, an idea of how Neanderthals walked. So again, we're designed as endurance runners and not sprinters. The bottom left from Encyclopedia Britannica, the references there, shows how the skeleton system is developing. And this is critical. I'm going to show how this skeletal system development is critical in storing potential energy. And in terms of running fast, a human, let's say at 200 pounds, can run, or 180 pounds, can run 8 miles an hour. A gorilla at 500 pounds can run 25 miles an hour. So we're not designed for speed. And the skeleton in the middle is Australopithecus, one of the early hominids. And again, we're designed as endurance runners. This is another paper. So how do we store potential energy? If I'm saying, and they're saying evolution designed us to be efficient. So we want to store ground force energy and deceleration energy to be used to propel ourselves. And it's in eccentric contractions. And we're going to look at those eccentric contractions. But subtle gait abnormalities lose this energy storage. And if it's not stored, it's destructive. Here's another paper talking about it. And then there's just, besides stored in eccentric contractions, the plantar fascia and the Achilles tendons are examples of structures that store energy. But in gait, in a healthy gait, primarily it's internal rotation, which is the leg. And these are all due to the skeletal structure and gravity. It's not active motion. the internal rotation, the eversion at the subtalar joint, and flexion at the knee and hip. And we're going to see, I'm going to look at one aspect of the beauty of evolution in designing this and how it occurs. So this is from Newman's book, or courtesy of Newman's book. But so when the heel hits on, when we're walking, the knee and the hip flex, but the leg internally rotates. This is not an active motion; it's a passive motion. And the subtalar joint is turning on the arch, and that's resisted by muscles that are stretching. So it's eccentric contractions. So evolution designed us to store energy, and that's very efficient. But if we don't store this, then it causes damage. So I'm talking about subtle gait changes. So if we look at this gait and this gait, overall, they don't look dramatically normal. They're not like Parkinsonian gaits or ataxic gaits. But I want you to look first, the hip's not moving much, but the kneecap and weight on the foot. So in A, and what we're seeing is that the kneecap is more or less point externally. But by the time we get to C, it's internally rotated when you're at mid-stance, when the foot is flat. And the foot has shifted onto the arch. So it's turned inward. So we've stored potential energy here. Now, this is, it's a supination gait, but the difference between supination and inversion, I'm not going to explain here. But we can see if we watch the kneecap, it never turns inward. And when the patient rolls their foot, it's all the weight remains on the outside of the foot. We are not storing energy here. And I'm going to come back to this one related to Sittersdisease, but on the left is a semi-normal gait. The heel strikes, and the immediate response at the hip and the knee is flexion. But if we have abnormalities in the flexibility of the flexors or tensors in the leg, or we have abnormalities in, for instance, proprioception, the gait is shortened, the flexion does not occur, and we don't as much or to the same degree, and we don't store energy. And just to look at our assessment of where center of pressure runs during gait, during the stance phase, you can see that it moves from that internal rotation and then external, and completes external during the swing phase. So we're going to do a functional movement approach. And this is dealt with what a functional movement exam is versus a current exam. So the majority of the exam are musculoskeletal exams are injury exams, and they're focused on one joint. So, whether we look at the sliding drawer or the empty can, sliding drawer of the knee or of the ankle, we're looking for injuries. And if it has to do with the nature of how medicine evolved. If we look at neurology and cardiology, they have corresponding surgical branches, neurosurgery and cardiac surgery. There's no internal branch with respect to the rheumatologists, who are great doctors, but a mechanics division to orthopedics. So the current exams are based on identifying problems that are surgical problems, and it's not even just purely injury gaits. I have a video on posterior lateral problems of the knee, which are usually not operating problems, but we don't examine those particularly well. And then the outcome studies are generally in neurology and cardiology done by the internal medicine side. I can't blame the orthopedic surgeons for publishing paper on surgical techniques, because that's what they do. We need more papers on, like we do in cardiology, these 20,000 patient study, and we're starting to see that with talented people like Katz at the Brigham in the musculoskeletal field. So in functional movement, joints are not independent. We can't view them as independent. We're looking at the body generally in motion, and the neuromuscular and neurosensory component are critical. And for this particular talk, with regard to the kinetic chain and joints being connected, we're with regard to how, as we saw in the figure that was generated, the center of pressure is kept, and then with the movement, how the center of pressure moves and the storage of potential energy occurs. And with gait, the neuromuscular and neurosensory, but example, the gait generators, which are in the cord and in the brain. So kinetic energy, and we're looking at dynamic kinetic energy. And I want to go back, and so you could see how you could develop on the left. We've seen this image once already. If you kept walking like this, you're going to end up with back problems. You can see by the shape in the back, stretching ligaments and muscles. But if we look from the side in Sittersdisease, we could see on the bottom, and I would recommend reading this section in Newman's book, we end up with problems when we have the flexors and extensors in maintaining, in particular, lordosis, which evolution designed lordosis for the bipedal gait. But also we see tight tensors tight flexors or tight extenders, which alter gait, as we discussed before. And we don't get that full, whether we have sensory problems or whether we have tight extensors or flexors. We don't get that same flexion at the hip and at the knee with Sittersdisease or sedentary lifestyle, and it causes problems in the musculoskeletal system, particularly with regard to energy storage. And this is just a paper on the evolution of lordosis for those who are interested in the lumbar spine. So neuromuscular and neurosensory. The control of gait is very complicated. So there are actually primitive gait generators, central pattern generators in the spinal cord, which are controlled, generally inhibitory, from the brain. And I'm going to discuss that. But also inputted is the cerebellum, the eyes, sensory information like proprioception is all integrated when we have gait. And so we have these rhythmic generators in the spinal cord, which are regulated, and it probably goes beyond the pontine, the pendicular-pontine nucleus, and this suprachiasmatic nucleus seems to be, in recent literature, the gait generator in the brain, the master regulator. It's getting input from sensory and motor. But I'm going to use an example with regard to ankle sprains. And I have to actually apologize. I don't remember the percentages, but I'm going to give you an approximation here. If somebody has an ankle sprain, the chances of recurrence are, if memory is correct, between 70 and 80%. But it's 70 and 80% in both ankles. So the programming in the brain for gait has been changed with an ankle sprain. And so the sensory information is not read the same way. So when we do exams, and this is covered in a different lecture, the functional movement exam, we do pronator drift, sequencing, proprioception as important parts. And just, there's been several papers looking at the link between at ACL injuries and poor proprioception. So if you think about a skier who's turned their head, if they have poor proprioception, they're normally using their eyes to know where their leg is in space. But you have the powerful muscles, the flexors and extensors at the knee, which if you turn your head and you have poor proprioception, you can't regulate those very well, and you tear the knee. You don't react correctly to stopping, and you'll tear the knee apart. And it may be that the major cause of ACL injury is poor proprioception, and that's covered in a different lecture. So now if we look back at some of these things, bipedal gait from looking at primates or looking at our ancestors, is critical in developing OA. OA is a problem with the center of pressure. In lifestyles, we didn't cover much in anthropology. We'd originally tried to look at skeletons from the Tigris-Euphrates Valley, but it turned out that they did a lot of work with their hands and a lot of sitting, and that there's a somewhat sedentary lifestyle, and so we needed to go farther back in the evolutionary change. Abnormal gaits deliver very high energies for long periods of time. We talked about where we get the ideal gait forces. We talked about animal studies where we alter gait and how rapidly OA and reproducibly OA develops the work, and the fact that OA since World War II has doubled, correcting for age and weight. And the fact that the subtle gait abnormalities that I showed you, and these are two examples of, overpronation or consistent pronating throughout the stance phase, or supinating throughout the stance phase, are very subtle, and they're missed most by the patient and the practitioner in the majority of cases. So these lectures, again, are not intended to manage an individual patient. They are not a substitute for seeing healthcare professionals, and we've talked about the reasons. And this is a picture from Marblehead, Massachusetts, where we're based out of, which hopefully is relaxing. Thank you very much.